Can view them later. Okay. All right, so welcome. I would like to just welcome you all. And I'll just turn over the mic to Dr. Cowan. We have quite a number of um, cases and other elements to discuss, and it looks quite exciting and content rich. So the only thing I wanted to mention, though, is today is the last of this round of sessions, and the new round of sessions are I didn't know if you were going to cover this, Dr. Cowan, but the new round is, I'm just trying to pull that up, is January, starts January 14th and will be held the 14th, 1st, and 28th. So for those of you who want to join again, we try to refresh the content and to some degree. Otherwise, it's more help you get secure in those guideline care standards and ASME elements. So that's January 14th, 21st to 28th, and new time is set. It's 1:30 to 2:30 to see if that works for some of you better than this current time slot. Okay, so Dr. Cowan?
Yeah, so do you have slides up, Karen, or do I just not see
Yes,
them?
I've got them.
Okay.
Does that work?
Nice. Yeah, so you can go ahead and advance the slides. So share, we have no disclosures today for myself, Melissa Barron, our nurse asthma educator, and Karen. Next slide. So recap what we covered in the prior two sessions. The first session, we had the asthma overview. We talked about asthma basics, medications, and devices. Then we talked about asthma triggers and tools for trigger reduction. And then today we're going to have time for case discussions, and we can go back to any content you're interested in and go through cases. These are the sessions that we'll cover again in January. It'll be at a different time, so that if this time hasn't worked for people to attend all the sessions, or if it's been a busier time, and also if there's people newly joining, that they will be able to have the same content presented and not miss out. Next slide. So today we're going to have an open forum for case discussions and questions. I have some cases to share, but it's also something we can come back to later. I'd like to prioritize if anyone wants to share your own cases or questions, and particularly if you have any questions for Melissa, our pulmonary nurse asthma educator, because she's going to have to hop off the call at 1. So if there's any questions specific for the asthma educator, welcome those now as well. So we'll pause it for a minute, and you can raise your hand or put questions in the chat. I'm glad to go through our own cases, but I'd rather prioritize anything that's coming up in your schools or anything that you would like to talk about today.
Yeah, Celine?
Hi. So,
Celine?
Solen, yeah, I'm the school liaison for the Department of Health in White River Junction. So this can wait. It's not a case presentation, but it is an issue that's been I've had a couple school nurses ask about, which is having stock inhalers in the schools, and so it seems from the information I found that schools, there's not like a statute like there is for epinephrine, but schools can have their own policy and protocol to carry stock inhalers. And there have been a couple toolkits that have been shared. And I was just curious, I'd just love to get the take from you guys on this topic, if you had any thoughts about it.
I'll open that to
Go ahead,
Karen
Dr.
to discuss. Yeah, because I think that's
Yeah.
it's a fantastic idea. It sounds like there's different ways to apply this and different questions to be answered. I know that's something Caitlin has been working on, and I'd seen something previously, but Karen will be able to give the latest and greatest. I'd love to hear questions, problems to bring back to that team also.
Yeah, I think overall there's consensus that it's a good idea. And the example that you mentioned, EpiPens and other life-saving medication on stock at schools is helpful. Caitlin has been trying to work with a subgroup to try to advance that and get information out as, to just educate where we are and what room and latitude schools have, but also to work towards a more centralized statewide approach in terms of policy. We've also, the asthma program has talked with other states for their successes, and their recommendation is, and this might be true also at the school level, is not to explicitly call out any particular medication, but talk about it in terms of life-saving medications, such as, and so that way that the policy doesn't have to change as new medications roll out or are needed or appropriate. So at present, I don't believe there's a current has been significant progress in actually achieving that statewide solution, but I would suggest following up with Caitlin and letting her know of the concern in the White River Junction area.
Okay, thanks. Yeah, and we've talked about it a little bit. I just didn't know if it had been successful in other places in the state or just.
Yeah, no, not in the state, but in the region, there have been a couple
Okay.
of successes.
Okay.
Is there anyone on the call currently who has this in their school already? I know in previous sessions there have been nurses. Is there anyone on the call currently that has that in their system?
Hi, this is Kate Rome. I'm a school liaison in the Springfield Health District, and I don't think I have an example of that in any of the supervisory unions in my health district, but I believe one of the supervisory unions in the Brattleboro area does have a physician order for, I think it's albuterol, and they wrote a procedure. So in order to avoid doing the whole school board approval that's required for having a new policy, they did a procedure.
Okay, that's great. Yeah, I've heard about that for other things as a way, so that's helpful. Thank you.
I'm not a clinician type person, so I can correct me if my language is incorrect. Dr. Cowan, is that I think some schools and or school districts have used like prior authorization by a physician that then allows for easier or faster access to certain medication, but I'm not sure exactly how that process has worked, but I've heard that wording before, and it may be a runaround, or a workaround rather, for accessing some of those supplies.
That may be what she's mentioning. But
Okay.
yeah, I think I've heard saying that school is not a prior auth, but it's a prescription that a local provider is giving for a particular school.
And just to state that I'm really pleased to see school liaisons and regions represented. And feel free to reach out if you, as groups, want additional support around any of the topics that we cover through this guideline care, and or ask me, especially as it relates to, getting more points and support around asthma-friendly schools as a way to get recognition there, but also to address some of these issues.
Yeah, I will say, I know there was a lot of interest, so I'm hoping people will be able to come to the next one. It was just a difficult time with like noon med pass. So I think
it's a difficult time.
I think it'll be great for next month.
Yeah, and if you have a good number of folks who do have some suggested times that might work better, please send those, and we can try to see if at some future round that we could, pick that as the time frame. So.
How about other questions or things anyone would like to discuss? Um,
Any recent challenging cases or school nurse office visits to highlight?
It's okay to save those up if you don't have one now or as things come up. We just want to have these in the future sessions too. It's fine to bring up any topic that you want to discuss with us or just troubleshoot with all of us as colleagues, because that I think that sometimes helps to see what's going on in other systems. I don't mind jumping through some cases now. We can advance the slides, and I'm glad to take pauses and just put in the chat or raise your hand if you want to share a case in between if something comes to mind, and we'll just open these up for a discussion. Okay. Okay. So I'm going to share some cases that have come through our office that to highlight some issues for schools and then highlight some of the reinforcing the content that we've covered already. So this first one is a 6-year-old with asthma and allergic rhinitis. They have exertional symptoms several times a day. They have chronic cough, frequent illness. They're pretty uncomfortable with chronic allergic symptoms, and they're prescribed low-dose QVAR twice daily, which they are taking with good adherence. So this is a child that came newly to my office with this information. And this is a situation that could easily come into school, and actually it was coming in to the nurse's office for the exertional symptoms pretty frequently and had quite a bit of missed school. So thinking through this one, does anyone want to comment on something you may want to think about with their asthma action plan or technique or anything like that?
Do I get to vote? Do I get to say something too
Yeah,
as a
of
non-clinical
course.
person?
I'm not going to call on anybody, so you can comment. I might call on Melissa. I can raise her hand if you would like to be called on, but I won't call anyone out.
I was wondering, given there's exertional symptoms and you say at the bottom there that there's 2 doses, twice daily rather, of QVAR, would there be a rationale for providing additional dosing prior to exercise or some planned exertion?
Yeah, so they do have albuterol. It's a good question. They do have albuterol prescribed, and they are taking that for exertional symptoms several times a day. It's hard for them to move around a lot. So they're taking quite a lot of rescue medication. Um, so some
Scheduled, the number is 802.
I would ask about maybe about their allergies and seeing what's going on with that. Dive a little bit deeper into that. What time of year?
Yeah, so they're taking antihistamine as needed, and actually not that often, just when things feel pretty bad. And they have pets at home that are really indispensable for their family livelihood, and he's not on anything other than that. So one thing we did for him was to treat with daily antihistamine and intranasal steroid, which ultimately helped quite a bit, but it didn't solve the asthma problem. So I can share some things that came out further in this conversation with the family. Um, they had a good understanding of what they needed to take. That the child needed the QVAR is an inhaled corticosteroid. That's something that you can look up. If you see something on the asthma action plan, you're not familiar with what it is. That's fine to look up. They came with this prescription, and the things I wondered about was, is this the right dose for him, or is it the right medication? Does he need a combination medicine? But the first thing that came out was that he's not using the device correctly. So this is a 6-year-old, and with a lot of training, often they can use the breath actuated QVAR device, but for some kids really is challenging and can't always get the hang of it. So developmentally, just seeing where that child's at and how, they handle that, concept and technique and their, supervision with the medication. The other thing they were doing with the QVAR that you can't do is that they were inserting it into a spacer. So they were trained with using their albuterol with the spacer, the MDI. And it wasn't something I was expecting, and actually didn't quite come out initially in that conversation, but they were inserting the QVAR into a spacer. So they really weren't getting that medication effectively. We always encourage you to insert the medication in a spacer, but not the breath actuated devices. So that's not correct technique for that. So for this child, we tried a couple of things. One was it didn't seem like, based on his level of symptoms, he needed more. And his technique in the office wasn't very great with the QVAR, even given correctly. So we troubleshooted that, and with his medications and dosing and technique. Over time, he ended up going back to the QVAR. Insurance was sort of a barrier for other things, and really working hard on the QVAR technique, and his asthma came under good control. So he wasn't having a lot of exercise symptoms. He was feeling like decent allergy control with those medications. So I just wanted to reinforce that piece about the devices, because that's something with putting it in the spacer. My first thought was that either he just wasn't doing the right technique and wasn't trainable yet at his developmental level. But in fact, he actually was, and they were just not giving it correctly. And the dose actually ended up being okay for him. And that's something that was a little harder to tease out, is how exactly are you giving that? And then we can advance the slides a little, and we'll just refresh some slides that we looked at previously about the devices. To recap, most reliable devices, especially in the younger kids, is that HFA MDI with the spacer and mouthpiece, or spacer and mask, which is probably the most familiar, that we've used pretty long term. The others are breath actuated. If they say Respiclick, Respimat, FlexHaler, Discus, DigiHaler, TwistHaler, ReadyHaler, these are all breath actuated, and the devices all work a little bit differently. You can advance to the next slide. I do like some of these videos these are Boston Children's YouTube. And if you just type that in the name of the thing that you see on their plan, if you want to know, what is that and how does that device work? If you wanted to look at it with the child, or if you wanted to look at it to refresh. I like these. Sometimes they go to the company website, but these all have children or teens in them, and that's a little more relatable for a lot of kids. Would anyone we looked at the QVAR one before, would anyone like to look at that again, or look at one of the other inhaler types for breath actuated devices?
Yeah, Kitty wants to see that one again.
You want to do the QVAR or different?
Mhm. See if I can get this to work. Can you hear it? Can you hear it?
Nope.
No.
I can't recall if it's just music on there, everyone. I remember last night, I look at these all the time and it just doesn't register because I just read the captions.
Oh, wait. There we
I
go.
can't remember.
Oh, that's not it. That's not right. They advance it. Hold on. Hold on. So you have to go back out and come back in with the sound scenario. Hold on, I'll get it. There it goes. Can you hear it now? Okay, sorry about if that sound didn't work. It shows it's on, but it must not have shared, but I had the subscripts. Oh, hold on. It's going on. Okay, sorry about that. Has a mind of its own. Do you want to watch any others? Maybe we shouldn't.
Isn't too bad with the caption. Want to try it?
What's
And we want
that?
to try it with the. It seemed like it was working with the captions, Karen.
Yeah, I could try that. Shall I try the ellipta?
Sure. Or try the Flex Healer. We see that one a little bit more.
Oh, okay.
Try the Flex Healer or the Asmonex one. You see those a little bit more, but it's nice to know where your resources are for this. I shared this for one of the resident asthma teaching sessions, and we went through a few of these videos, and I think there's a lot of look of horror of what we prescribe all these things, and they're all a little bit different in the technique. It's the same premise, but all the devices need a little bit of care and a little bit of how you activate them, and they're all slightly different. But I think my point was you don't have to memorize them all, but know where your resources to find it. The family will have to become a pro at using it, though.
Let's see. Yeah, it's not wanting to go off your slides.
Karen, could you share with the group after the talk, like that slide? Would that be helpful to anybody, just as a refresher of where to find this stuff? Would that be
Yeah,
okay?
I'll definitely do that. I'll
Okay.
share that through like the newsletter or something. Yeah, I was gonna see about going around it, but I think with time, maybe not.
Okay. So we can, if you want to go to
Oh, wait, it pulled up.
number,
Hold on one more try.
okay. Any luck, Karen, or should we move on?
What's that? You want to
Should
move
we move
on?
on? Yeah, are you showing something that I can't see, or should we move on?
Oh, you can't see?
No. Maybe we should
Yeah,
move
we
on.
You're all
see
The
done.
videos are.
Good job. This is the
That's
swelling
that's
or
it. Sorry.
inflammation of the The Pulmicort Flexhaler is a dry powder medicine that reduces the swelling or inflammation in the lungs. It is used daily to prevent asthma symptoms. The inhaler comes in 2 different strengths of medicine, 90 and 180. Check to see which strength you have. You can tell how much medicine is left in your inhaler by looking at the dose indicator on the side of the container. If there is a red mark on the dose indicator, there are less than 20 doses left. This means it's time to order a new inhaler. When the dose indicator is at 0, the inhaler is empty. Throw it away and start using your new inhaler. Be sure to keep the cap on your Pulmicort Flexhaler when you're not using it to keep the medicine from drying out. For the best results with your inhaler, follow these steps. First, wash your hands thoroughly. Next, hold the top of the inhaler upright and twist the bottom to remove the cap. Twist the brown part in one direction and then the other until it stops. You will hear a click. Hold the inhaler under your chin and breathe out. Then put your lips around the mouthpiece of the inhaler and breathe in quickly. Try to hold your breath for 10 seconds. Count the time on your fingers. Breathe out. Then put the cap back on the inhaler. Finally, rinse your mouth with water and spit out the water. Repeat if another dose is necessary. You're all done. Good job.
Okay, success. Finally. Sorry about that.
And I think that one contrasted it with the one we saw before with the Q bar previously. So the Q bar that one looks like a tube, and you kind of deal with twisting that cap. And the Q bar looks a little bit like the typical MDI, but it's not. And it's actually with the cap. So you can see where those can get confusing for families to have devices look a little bit similar. You wouldn't put a Q-Bar Redihaler in the spacer, but you can see where that they might be tempted to try to do that. So we can move on. Karen, I'll tell you which slide to go ahead to. Let's go to slide 15. No, let's go to slide 13. Okay. And that's okay if you peek at the slides in the side to see what's happening next. So we'll talk about this 9-year-old with moderate persistent asthma who is prescribed inhaled steroid with LABA, so ICS formoterol with Dulera twice a day. He has frequent exertional symptoms, limiting sports participation. He really enjoys sports and can't do quite a lot due to his asthma. He does take has a pretty significant history of difficulty with illness and history of ED visits for exacerbation. Next slide. So we'll talk about next steps. So this child done a lot of work on education for self-management by the family and working on some independence for the child. So they have actually a good understanding and appreciation of how the medications work. They have pretty decent access at the pharmacy. We worked on some of those issues. So they have the medications in hand. They are able to get them regularly. And he doesn't have, a lot of allergic triggers. There's some smoke exposure triggers, and the family really works to limit that to outdoors. And the child, you have some worry about symptom perception because he's been pretty symptomatic for a long time. And we've talked about treatment goals where he really would like to, not go to the ER. As with the family, he'd like to sleep better, and he'd like to be able to participate in sports and miss less school. Um, so, what are some thoughts? And it's okay if you peek at the next slide on the side that we kind of took a peek at already.
There's your peak.
Mhm.
Going, gone. Oh, do you want to look at it for a longer time?
Yeah, we can leave that up.
Okay.
Um, so this child, um, we've spent a lot of time on, and we see this a lot, where sometimes we can remedy the issue with, whether there's supervision issues or, um, and reminding to take the medications if there's lots of caregivers. um, this family really had a hard time with adherence. So that's sort of the bottom line here, is that this child has the prescription and knows how to take it, always uses a spacer, and is still really symptomatic because he's just not, taking it. And the family, they appreciate it, is that they just can't swing it at home. There's other kids and things are busy and there's multiple caregivers and he's still pretty young. Although we do see even young teens aren't able to do this alone without a support sometimes. So this child, for, now this child's a teen, but for a number of years, starting, when he was in older elementary school, we changed to school administration of his Dulera once a day. And the family was able to do it at home once a day as well. When they started to see, they became more motivated, actually, when he was doing better, and he became more motivated to push for that when he was feeling better. He still wasn't able to swing it to do both doses at home, but the family was extremely appreciative of the school plan for that. And we do get some families who are not, have, some hesitation about that. But this child was someone in the office already a lot. And we talked about that a lot of families do appreciate when, being able to do one of the doses at school, and, appreciate being able to meet their treatment goals that way. And this family has continued to be really grateful over the years that he's been able to do that. Um, the challenges come with holidays, weekends, summer vacation, but this can be, life-saving or life-changing for a lot of kids, where adherence, there's major barriers for kids. And this is one example of, one of our patients who has to do this plan because we've exhausted other home options. Does anybody have kids at their school who receive a dose of their green zone maintenance medication at school? Not right now, does he? Yeah. Say the majority of our patients are, are able to, find some sort of creative plan where a dose a day will work at home, or figure out the, additional strategies for adherence at home, like setting alarms. One way that we have them to, like, set a cell phone alarm and say, like, you have to take it when it goes off, no matter what else you're doing. You have to go do it. There's other, techniques to try, have, rarely, like, a paper checklist is a rare thing that whereas a family uses that. So we've worked really hard to find something that works for the family, but it does happen sometimes when kids are having frequent exacerbations, and, it's pretty high risk, where, changing things to get that support at school has been really important for the child, and actually help the child learn and become really invested in the plan to be able to work on that themselves as they get older. Next slide. So this one, I want to reinforce what the main treatment for persistent asthma is. This is a 5-year-old with cough or wheeze associated with exertion 3 to 4 times a week and nocturnal cough weekly. Um, you can treat with, rescue medication, right? So this child, for asthma, should have albuterol as needed for symptoms, but the frequency of the child's symptoms and um, the the degree of symptoms do put this child in a persistent asthma category. And we can go on to the next slide and talk about just to review, the first line therapy for kids in a green zone that you'll see for kids with persistent asthma, or you might see kids just having a yellow and red zone with albuterol who are coming in for a lot of symptoms, those children might benefit from inhaled corticosteroids, or at least an assessment of what's going on with their asthma control. So what we see with inhaled corticosteroids, this is a first line therapy. This is the most effective, and this treats the underlying problem of inflammation. It does regulate the beta 2 receptor, so it helps bronchodilators work better, improves mortality rates, and it improves the other things we want to see, like reducing exacerbations, ED visits, and improving symptom-free days so they can attend school. Next slide. Then we'll talk about the next steps in therapy when inhaled steroids alone are not treating symptoms. It's a 10-year-old with asthma who's chronically on a medium dose of inhaled fluticasone. This is formerly Flovent. They're adherent with therapy. They use their spacer correctly, but they continue to be short of breath playing soccer despite pre-treatment with albuterol. So they're limited in their activity. They continue to have nighttime cough several times a week. They have a previous history of a negative allergy workup, no current symptoms, and their lung function is mildly low. So 75% is some mild airflow limitation, so abnormal. So we should talk about the next step in therapy here. Next slide. So next steps for this child who's not well controlled with inhaled steroids alone. That typically the next best treatment is an inhaled steroid with long-acting beta agonist. So you may see a child who, if they're having frequent symptoms and they're on inhaled steroids alone, you're thinking about, are they taking the device correctly? Are they taking it? The step-up therapy that tends to be most effective is something like Symbicort, Dulera, inhaled steroid with long-acting beta agonist. We really see this being effective in kids with frequent exercise symptoms, nighttime symptoms, and bringing the symptoms under good control. Next slide. Okay, so this one is a 6-year-old with moderate persistent asthma. She's prescribed Symbicort twice daily in the green zone. She previously came to the nurse's office only during colds to get yellow zone albuterol, and now she's initiating coming into the office once a day and then eventually twice a day over a longer period of time for albuterol, even when she was well. And it's usually after recess or gym class, but then she would come in an additional time a day. Let's talk about next steps for this child from the nurse's perspective. Are there things you want to know or anyone you want to reach out to?
Would you coordinate with a PE teacher or coach if there's regular symptoms after exercise?
That's one good idea. I was thinking about pre-treatment more for that exercise. Does it make you worry about this kid when it's been a big change and now they're coming in twice a day? It's got once a day, now twice a day, and that just hasn't been like them. It's a great idea to think about pre-treating before. And maybe you would have done that, coordinate with them if, when it was just the occasional before exercise. I can share what did happen here because this was my child. And so she was coming in. I didn't know this, that she was coming in, but I was really grateful for how the nurse approached her and reached out about it. So she was coming in, started to come in pretty often, and then what the red flag was for her was she talked to my child about what she was doing. She went through the asthma action plan with her. It was like seemed like a little young for 6, but it was actually pretty effective. And she's like, "What are you taking at home?" I see that. "Are you taking any medicines at home?" And she said, "I'm taking the red one in the morning and at night." And that sent up some red flags for the nurse to find out like what my child thought the red one was at home. She didn't know the name, but she was taking a red one at home, and she had a red ProAir albuterol at school. So the nurse started to panic that she's now potentially getting albuterol is she getting albuterol 4 times a day and nothing else, or is she taking the Symbicort, or what was going on? So the nurse reached out to me, just said that she had checked with my child, and to see, what is she taking at home, and how I think she's doing with that, and the technique, and going over those things. And so it turns out we figured out, that she was taking the Symbicort twice a day, but things really weren't going well for her symptom wise. So we were able, an RN, to reach out to her provider to, prescribe, and they ended up prescribing a higher dose of Symbicort. So step up therapy, because what she was taking wasn't enough. But this certainly comes up a lot, where we see that this happens to kids and it ends up being either a adherence issue at home or a technique issue. And there's different ways people have navigated that, whether, typically starting with the family, or whether, you know, needing to, get permission to reach out to their primary care if that is helpful for the family. But for us, I did appreciate on the parent end of the nurse reaching out to say that something wasn't going well for my child. And I've gotten lots of reach out from the nurse over the years for my children, for this, when I think things are going okay, and they're like, "Well, I really wish I had something else to do for them because they're in a lot," or, and then helping, figure out what the next thing to do is. Exciting. So this one's a 13-year-old with severe persistent asthma. She's on Dulera, which is mometasone formoterol, at a high dose twice a day. She's on tiotropium, which is Spiriva, daily. Her adherence, I would say, is fair. So she's adherent with montelukast and histamine and nasal steroid, but she continues to be pretty miserable with allergic rhinitis symptoms. And she's chronically using albuterol 3 to 5 times a day for shortness of breath and cough, and she doesn't go anywhere without her albuterol. And I'd say that even with times when she had been adherent with twice daily Dulera, then she was still having pretty much the same problem. So it wasn't super appealing for her to take the Dulera, and that's sort of where some of the fair adherence came in for her. Um, what do you think from these options seem like a good next step?
You have
Or
one
next
vote.
slide, Karen.
You have one
Got a
vote
vote?
for,
Do
you
I
have
vote?
one vote for check spacer technique. I was gonna vote for smart therapy, but I know I'm not a clinical person, so what do I know? And so shall I go to the next slide?
Yeah. So, so whatever you pick, you're right. If you picked any of these, go back, go back one, Karen. Um,
Oh, sorry.
so probably no one voted because you could probably see it on the sidebar.
Oh,
Sidebar. But yeah, all of these we did for her. So it's definitely, her device technique is fine. She's actually bringing a spacer for her albuterol with her in her pocket, even though it's inconvenient because she needs it. Um, so we did offer, just to try to bolster the adherence, even though things were no better when she was taking it well, to do school administration maintenance therapy. At this time, she was switching schools. She was adamant that she would not do that. Um, So we went on to some other things as well. So the device technique was fine. And for this child, we did, we had planned to add a biologic, which is a step up therapy with an injectable medication to treat her allergic asthma. That can take several months to get approved. So they have to document adherence, get the prior authorization. So that can take some time, and she needed something right away. So smart therapy was the ideal option for her. And this actually, for this child, this first started for her prior to the guideline update for smart therapy. So it was really challenging to get enough covered for her. So once the guideline changed, we were able, the GINA guidance to the global asthma guidelines has had this in there for a long time. But for our, our NAAPP guideline update didn't occur till a few years ago. So we couldn't easily get extra covered for her like we can now. So smart therapy can really be life changing for a lot of kids. This is a pretty dramatic circumstance, but basically, if this child uses her Dulera instead of using the albuterol every time, she should actually treat her problem better. And then that to bolster her adherence. And this child's really frightened of being without her albuterol because she can't breathe. So the plan we made was sort of an intermediate plan where she could do either or. So she wouldn't have that fear of being without it. We prescribed enough albuterol for her, but had her plan to carry her Dulera, focus on using the Dulera when she had symptoms and having it be her first go-to. So make sure to take it morning and night, and then keep that in her pocket with her. And then when she was short of breath, take that, and then keep track of how often she was going to take it. And this and so we can go to the next slide where we're talking about the smart therapy. So for her, that ended up being helpful to where she ended up on about 3 doses a day of Dulera most days, and having her asthma be under pretty good control. Lung function was much better. She was feeling much better, not feeling frightened that she couldn't breathe. And she felt pretty confident with that plan. So she didn't carry the albuterol anymore once that was working for her. So just a reminder about smart therapy. So if you're seeing someone bring in Dulera or Symbicort, are the only two we have that you can do this with, because they have inhaled steroid and formoterol in it. It's that formoterol component that you can do this with. You'll see on their action plan, if it's ages 4 to 11, 8 puffs is their maximum over 24 hours. And in 12 and up, 12 puffs is the maximum over 24 hours. Next slide. Let's go over just one example of this smart therapy plan. On the other sessions, we went through, several examples of how that can look. And well, just to remind you that can look different. So you may see some kids who have a smart therapy plan that they're mainly using at home because they don't have enough of their Symbicort, for example, due to insurance, or they're transitioning to that plan and they're not sure, or the family's not comfortable with the change. So sometimes they'll have either or. So Symbicort, albuterol, and they might only bring one of those to school, and that would be okay. For them to just have one. I had it come up once where the nurse had asked the family, like they were going on a field trip, and they thought the family needed to bring both in so they could go on the field trip, the albuterol or Symbicort, but that would be okay. They worked it out with the parent, but that would be okay to just bring one. They can have a rescue medicine, or they don't have to have both. So it doesn't have to be a choice. So sometimes you'll see both on the plan, but they would send one into school. Typically, that's when it's limited by insurance. I'll say at our house, I have a child we do smart therapy for him, but he does have albuterol at school because we can only get one inhaler a month for that. So we kind of fill early, so we have a few extra puffs to use for colds at home. But at school, he has albuterol if he would happen to need something when he's getting over a cold. Not ideal, but it works for us fine. In this plan, just to highlight, this teen has the maximum written on their plan. And as an action plan with smart therapy, really technically the dosing is just as needed for it. Often we'll put some parameters on just to guide the family a little bit, or about how often, or just to keep tabs on how often they're needing to take it. But they certainly can take it earlier than 4 hours. That would put them, if they're needing it earlier than 4 hours, you give their red zone dose. So that's one challenge of the asthma action plan as well. when is it too often, or what would you do next in that? And that's something that comes up a lot that we go through with families where, if they're at their maximum puffs for the day, then we would need to get urgent care, emergency care, or switch them over to albuterol while we're doing that. Um, One thing that brings up too is, I talk to families about, being in touch with school about how, if they're getting puffs that were unexpected. So if a child's gotten Symbicort a couple times a day at school, a parent wasn't expecting, that probably is something they need to know about, because if they're getting it frequently for illness, they would need to keep track of where they are and what their maximum is. Just like if they were getting, frequent albuterol that the parent wasn't expecting and something urgent came up like that. Next slide.
Dr. Cowan, quick question.
Mhm.
If you have a student with poor symptom perception and they're on SMART therapy, do you see that much where maybe they're not taking it enough? In other words, their
Mhm.
underlying issues are getting worse, but they're not perceiving it as worse. So then they jump right over into like a more serious problem. Do you see that very much with those on SMART therapy in particular?
I mean, they should do better on SMART therapy.
Anyway, okay, yeah.
Yeah, because they want, if you are relying, like this child in the case, if you're relying on albuterol when you get really bad, like she was,
Mhm.
um, take your Symbicort or Dulera instead. You'll eventually be dealing with the problem. You'll get some maintenance doses in, and you'll be treating the problem. There's really not, unless for a particular child felt better with one or another, the formoterol has the same onset of action, lasts longer. So, you get in the same trouble with poor perceivers with, um, albuterol. You take it only when you're really bad. It doesn't last very long. You end up taking more doses of it. So, and you're not getting any handheld steroid in. It does make people rely a little bit on that when they get that bad. So overall, smart therapy is good for a lot of things. I mean, there's occasions where, if someone doesn't tolerate Symbicort well, there's other reasons people might not be on smart therapy, or they only tolerated Advair, which you can't do it with. So there's some other circumstances. So not everybody is on it, or they're well controlled otherwise. But it often is a good thing for poor symptom perceivers, and a good thing for people who are not super adherent with their maintenance. Overall, this, if you're looking at like a population basis, the reason for this is it reduces morbidity mortality from asthma.
Thank you.
And we're thinking of this child who is having pretty frequent rescue medication use and pretty severe symptoms. That child's at really high risk of exacerbation, um, serious exacerbation as well. And it's really worrisome when a child's been chronically taking albuterol multiple times a day and saturating all their receptors for that. It's very hard to treat if they're getting into trouble with an exacerbation. So getting that under control is really imperative. This child had a lot of social factors affecting adherence with a very sick parent at home, and was really doing a nice job as a young child on her own, trying to be adherent in that, but really had a like low, resources in terms of adult, partnership at home, because they're had a lot of stress in the family. And I think some of the things that come up, we see, we talked about, obtaining medications, and that's hard if there's, parental stress or work schedules or things. And we see a lot of delays in pharmacy, a lot of shortages in medications, whether it's supply chain or what. So we're seeing that, lately, where someone is switching devices, and you see those videos, right? They switch a device and it's different, then they have to learn that new thing. You can't just send in a prescription without, following through on what is the device they have. And then we think about whether if they can bring medications to the visit, bring the device to the visit that they're using, and then checking their refill history is what we do in clinic too. And that sometimes helps open up the conversation, because sometimes um, families think that they're, getting something, and they're getting something different than we thought from the pharmacy, or not getting it as often as we thought. And that helps the parent check in more about the refill schedule. Also, the devices, the MDIs like the Symbicort, those will spray forever. So it is fairly easy to think it's working if you haven't looked at the counter lately. It'll just go on forever, hundreds and hundreds of times. So they certainly can be adherent with envy getting no medication. So I think we can pause here for wrap-up questions, and we'll save some of these, one more case to cover about exercise, we can cover in January. So other questions or comments?
I had a question about the breath actuated inhalers. Do you have any indication, you use that handout that shows how the difference in how much medication gets to the lungs with the regular inhalers? But do you have a sense of how much and how successful those are using the breath actuated even for kids? Is that medication getting to
There,
the lungs?
it will get to the lungs if you use it correctly every time, and if you have enough force to generate to actuate it and to inhale it. So you certainly can, for example, click and open, you've activated it, and you certainly could take it, take a breath and not generate enough force to extract the medication and not get it. So you really could be looking like you're taking it and not getting it in, if that makes sense. So it would be sort of the same principle. The photo, that simulation there of where the medication goes, it could be similar. Like you're not getting much, if anything at all, if you don't use good technique, versus good technique will get it in your lungs. I wouldn't show that picture because I don't want them to use a spacer with it, like that, but I might give that analogy, like with the albuterol, if they have one of those other ones. But it's a really big deal with the little kids. And then the other is like, it comes up a lot of the discus, like if you're storing it kind of wet area or thing, it messes with the device. Um, so that we worry about in little kids, but they can be trainable. And before we had the MDIs, we trained a lot of kids to use that. It's just we have better now. So I wish insurance could do better. The other thing is like the shortages, and switching around the medications, to think about, or if they have two different devices they use differently. It is frustrating for a lot of people.
Yeah, thank you. I do see that we're at time. I put up the slide again of that we'll have a, happy holidays to everybody, and there will be a break, and then we'll resume the next round on January 14th for 3 weeks in succession at a new time, slightly changed, 1:30 to 2:30, to see how that works. And maybe in the future, I saw that there was a request for something after 3, and see whether we could maybe pull that off at some point in the future. Any comments, Dr. Cowan?
I have a comment about the after 3. If anyone can share with Karen how feasible that is for nurses, like that definitely works for me. But in the past, that has not worked for nurses to do it after school, or like immediately after school has not worked for everybody, or very many people. So, but if it is a time, like we're glad to hear about, what might work for people. But yeah, after school has been a time that wasn't as favorable in the past. But if that's changed, please let us know.
Well, thank you, everybody, for this participating in this round, and happy holidays, and we look forward to seeing you in the new year. And be sure to reach out. I put my email in there if you have any issues with trying to collect CEU credits and or want more information. Thanks so much.